Monica Price is our internal medicine physician out at Hawaii Kai, and she's the chair of our primary care redesign work group. And I'm very happy to have her come up here and tell you about what she's been up to.
Well, thanks, Jared. I appreciate it, and thank you all again. I just want to echo the sentiments of Ray and Jared for everyone taking the time out really to come here tonight. Busy clinic days and family time being kind of sacrificed to come and talk with us. But I'm hoping you can enjoy some good food and wonderful company, and then we can get some business also kind of taken care of. What I would like to do tonight is kind of give you sort of an update or a recap of where we're kind of at in the whole primary care redesign work group project. This was a work group that was first chartered out of the Hawaii Health Partners Quality and Clinical Integration Committee in October of last year. So they already had great physician leadership and a really multi-specialty sort of work group that started the ball rolling. And when I jumped on board around February this year, hard work was already being done, progress was getting made. So I'm actually very privileged to just kind of update you on what's been going on this year with really the hard work from our whole group. Primary care redesign, a lot of the primary care members in the audience tonight a lot of this will sound familiar to some of our hospital specialists or base specialists or our surgical specialists. This might be the first time you're kind of hearing about the work that we're doing. I will guarantee you will hear more because we're starting very primary care centric and concentrating on that right now. But the hope is that this model will continue to bloom and grow, and so we actually become a very expanded team-based care involving all specialties, so that we can kind of take care of our patients, help to reduce costs and really increase quality. So that being said, the progress to date and sort of the lessons learned up to this point. The goals of the group started out, I think when I first joined, I kind of felt that we were going and trying to redesign primary care more based on sort of the global payment transformation that is on the horizon. But the more I thought about it, really we need to help to get the burden of practice off of our primary care docs. So even before the conversation started about primary care reform, or before payment reform, primary care docs, we were just getting overwhelmed. There were more measures to meet, more patients to see. It was hard to just kind of keep above water, so to speak. So a lot of us are starting to lose our love of practicing medicine, and we really want to incorporate in our redesign to bring back sort of that intrinsic joy of medicine, bring back the doctor-patient relationship and make that primary so that we can go to work happy, and then I think a happy doc kind of fulfills a lot of our other goals. So primarily really to reduce the burden of practice for our primary care docs. And then from there, pieces will start to fall into place, and so although kind of lofty goals, I think we can meet these as far as increasing patient experience numbers or to the 90th percentile, to improve quality outcomes above 90th percentile as well. Again, echoing what Jared was saying is reducing cost through reducing ED admissions or ED visits, hospital admissions and readmissions, and really kind of incorporating that into the primary care redesign as well. Payment transformation is a big component of this, and it cannot be forgotten. So we need to create a sustainable model that we would be able to, that it's doable, that is for the independents as well as the employed physicians. So we're really ready when the fully global payment comes our way. So we're ready to take that on. And in all of this, and really to keep us sustainable and to keep our specialists busy, it really comes down to our attributable lives. And the hope is if we can give more time back to our primary care docs, that time can be used to grow panel size and to make sure severity coding or the accurate coding is done, and to make sure we're maintaining that primary care or the patient chart as well. So all things that are going to be vitally important in payment transformation. So this year, this is sort of just the milestones and kind of a timeline of how the work group, and we're hoping to sort of progress. This year, we really wanted to define what team-based care meant and to make the case to our primary care members. So going out to the private practice, the private practices and our employee practices to really give them the idea of where we're headed. We're starting with small tests of change. So at the beginning of the year, after making that case for change, over the summer, the team has been working hard at really trying to incorporate these small tests of change to improve existing practice efficiency, basically. So instead of growing and jumping right into an expanded care model or team-based care, start with our own practices now, improve the efficiency, and then kind of moving from there. The hope is that we'll be ready to, in the next few months into the beginning of next year, to really dive into having some of these pilot practices go into a fully expanded care team so we can learn from them. So it's all about learning what works, what doesn't work, who needs to be part of this team base or this team as far as the primary care team. So all lessons that we're hoping to learn within the next, hopefully, few months into next year. Into next year, it's all about getting good at the expanded team and then rolling that out to more practices so that eventually we are going to be having to grow our panel sizes and our attributable lives like I said earlier. So that's the hope into the next year. HCC, the hierarchical condition categories is going to be vitally important, like I said, as far as our reimbursement. We need to know not only who our patients are, but how sick are our patients, and that's going to go a long way as we become more knowledgeable and have hopefully more time to be able to devote to that kind of documentation as well. And then kind of mirroring what Jared had said before, over the next few years, 2018, 19, 20, there's going to definitely be changes as far as the primary care compensation through the independent docs as well as the employed docs, and we're really going to have to start emphasizing how we're going to make it, how we're going to be better care coordinators from primary care, through our specialists, through the hospitalist-based specialties as well. That has to get tighter, and that has to get a lot more efficient. So as the compensation model changes, we can survive that, so we need to get better at that too. And then again, 2019 into 2020, really expanding our, hopefully, sort of the ACO contracts with independent payers, the CMS changes that Jared alluded to, and then hopefully by 2020, we're in a good position to be able to take these patients, grow our panels, take really good care of them, and do it cost effectively. The project plan really starts with the first couple steps over the last few months. Our primary care docs that are in the pilot programs, this sounds very familiar. We are really concentrated on pre-visit planning as far as what we could work on as far as the efficiency of an everyday kind of clinic workflow. The thought was we need to make sure that we know who's coming in to see us that day, for what do they do for, can we be more efficient in that instead of scrambling before we walk in the door to find those answers. So our team has been very good about developing with Epic and the IT folks or a pre-visit form that will hopefully be sort of a screenshot in a form that primary care docs can kind of look at and easily assess a lot of the information we would have done and kind of searched around Epic before, all in one place. So that's what, from our standpoint, but the hope is that our team members, our MAs, our front desk staff, they also have a workflow that they're starting to implement that will hopefully help take a lot of that pre-planning away from the day of the visit. So when the patient shows up, we're ready to go, and it's much more time efficient. Along with that, so it was going to be sort of at step 2, was also the HCC coding. So this is sort of the risk adjustments, the payment transformation portion of this. It's going to be very vital that we get good at this and very knowledgeable about how to do this well and efficiently. It doesn't have to be us specifically, but our MAs, again, our staff, getting very comfortable with how to get the patients coded appropriately. Right now, in Epic, there are some best practice alerts, and that will at least give us some direction and kind of help us through the beginning part. So it's going to be a sort of a steep learning curve, or I should say time intensive, until charts kind of get caught up. And but once that's there, hopefully it'll be much easier. And finally, we were going to roll out, as far as a small test to change, is sort of the Epic in-basket, sort of the black hole for all of us, thousands of messages. And in fact, we'll talk about that in a little bit, kind of come through that really none of the physicians need to touch. We need to figure out a better way to help manage that and help give time back to the physicians. It was a little sticky as far as our Epic capabilities and what we could do from a technical standpoint, so we kind of regrouped and we're working more along sort of process or workflows in the clinic, and the hope is that we can start rolling that out to a few pilot practices and see how that goes within this next month. So we're on the way. So through the summer, we actually, as of our last meeting in August, of about the 130, 140 primary care members, 22 of the employed, both here in Kauai, and about 15 of the independent docs have already started the pre-visit planning and workflow in their clinics, and the hope is that that continues to roll out, and so hopefully by November, like you see here, maybe 80 practices, maybe more. So we'll hopefully have some more to report back on what's working and what's not. Really into next year, we got to take that leap. I think things work slowly, things are a little slow for my taste sometimes, but I think we really need some practices out there with sort of a primary care straw man, so to speak. Who is part of their team, what works the best, who do they need part of their team, and we really need to start learning from that as well. So again, just sort of that summary of the small tests of change that happened this year. I do want to point out a little bit of this, just to mention this provider utilization profile. James Lynn and his team have got some very interesting, I think really dynamic data from Epic as far as how physicians use Epic, how much time are we spending in it, where in Epic are we spending the most time. This is data very much in its infancy, and we're not exactly sure how we're going to utilize that to help physicians individually improve and become more efficient. But the data is pretty exciting, and it's really interesting how they can kind of gather that. And hopefully, that can help to guide us a little bit on how we can improve practice efficiency in the long run, and especially through Epic. And then again, as mentioned, hopefully the in-basket efficiencies are going to be worked on, and that'll be starting next month, and we'll see how those workflows go as well. More in detail, we don't have to go through this as much, but the pre-visit planning was really a lot of hard work with the team, and like I said, in conjunction with Epic and the IT folks, to build a pre-visit form that at that time, the idea is the form will come up, our front desk staff, our MAs, a couple days before the visit could utilize and go into that chart and look to see what the patient's coming in for, what do they do for, how can we make, get caught up on health maintenance dues. So a lot of those things that can be done ahead of time versus on appointment day. At the form itself, you have able to look at recent labs through sort of the hyperlink. You can see their ED visits, hospitalizations, imaging, all the things that would normally kind of click around, to kind of find what's been going on with this patient since they last saw us, all in one form, which, the hope is that that'll help with the efficiency. And the good part too is that sort of the last 6 ambulatory visits, so the last time they saw us, we can refresh our memories on visits and all of that in our notes. Just handing a physician in their practice the form itself didn't give us, I guess, sort of the feedback that we thought that, this is godsend, we're going to work beautifully. We needed to sort of work into helping to train the staff and the docs how to utilize this and how to come up with sort of that workflow in their clinics that works the best for them. And the hope is, at the end of the day, we get some better feedback as far as improved efficiencies, and hopefully that we're optimizing the care between patients and physicians, because that's ultimately the goal. A little bit about the HCC coding. A lot of the primary docs know about this. Specialists may as well. This is going to be something we're all going to be wanting to get very familiar with. The risk adjustment, how sick are our patients, is going to directly relate to our reimbursement or how we're going to get paid. It's not overbilling, it's not overcharging or overcoding, it's just accurately assessing the patients in front of us and coding appropriately. A lot of that is just learning how to do it and play sort of the game and jump through the hoops that we get rewarded the most for. So, for example, our depressed patients shouldn't be just depressed. We need to really qualify that and say a major depression single episode, or other things that will get us more not necessarily credit, but will, the reimbursement or what we get paid to taking care of this patient will be appropriate. Same with our sicker patients or our patients with multiple illnesses. It definitely behooves us to lump together. So instead of just our diabetic that happens to have neuropathy separately, we need to code diabetic with neuropathy. So little things, like that we're going to have to learn how to get pretty good about doing. And the hope is that we have some help for everyone to come out, and the folks that really know how to do this well can offer insight, and so hopefully some help in the long run. What we're moving on to is sort of the in-basket. When I first saw these numbers, it was kind of astounding, So they kind of took a look at us system-wide over 6 months and counted on how many in-baskets were floating around Epic. And it turned out to be 3.3 million in-basket messages, with 84% of those going directly to the physicians. So it's a lot, it's a lot, and a lot of those we don't need to touch, and that's where the team-based care comes in, so we can more appropriately get those messages to the ones that are appropriate to us, but otherwise taken care of and done and out of our inboxes, so we're not clicking, all day. So really, in the next just few minutes here, what's coming next? So like I said, I want to kind of dive in, and I would really love to see some pilot practices, get the full team-based care up and going as soon as we can, just to see what works and what doesn't work. Looking towards systems and groups and nationally, ACOs, those that have employed sort of this team-based care have really shown good results as far as happier patients or happier physicians, happier team members, better patient care, so the quality is good. And then again, the all-important sort of the sustained reimbursement in our new moving towards sort of that payment reform. So right now, most of us, not all of us, but most of us have a team that kind of looks like this. It's me, it's my MA, I have my front desk staff, and then we have the care coordinators that do excellent work to help us keep our HM dues up to date. But really, it's me and my MA against the world most days, and it can kind of get a little lonely, a little frustrating, a little overwhelming. So that's where the help comes in. That's where the hope is that we can help our primary care docs by building and expanding this team, both locally at our clinic level, so moving more towards a 2 MA system for each doc, but then with kind of shared support, whether on campus or right there in a clinic or more centrally based. That's what we're going to have to learn about and see what works the best and what is the most cost effective, and who should be part of our team. That's also another big question that we're kind of working through right now. Behaviorists always kind of top the list besides second MA work, just because we know the psychosocial determinants of health are huge, and we don't have a lot of time to deal with that all, as per each visit. And if we had some folks who really help us out, that would be a way to go. But social work as well, health coaches, nutrition, and the all-important complex care program that is done beautifully as that expands and offers some more options for us, for our sicker patients, all of that part of the team. So again, a work in progress there too. Finally, really kind of working on, or the final couple slides here, just how we're looking at primary care, sort of the team-based care, and how we're going to slowly fold in our specialists to be really part of the big sort of expanded care team. Starts at the middle, really with that patient-physician relationship. And the more time that we can have set aside for docs doing doc work and doing what we do best, it just makes the patients more engaged, and they too will be a strong advocate and partner for their own health. So that's the hope. All the sort of the gray boxes around are all sort of the different components as we're building towards that, starting with the small tests of change and the practice efficiency, the data analytics, like I said, very important to see, to sort of set priorities where we need to focus our sort of finite resources, expand that team so that the PCPs feel supported in their everyday clinic life. Complex care is going to play a huge role. Flexible access, so maybe not face-to-face, but more My Health Advantage or even telephone visits, so things that we might not feel as comfortable with now, we're going to start to grow and hopefully become more comfortable with that. And then again, the medical neighborhood, our consults, our care coordination, much tighter, much more seamless. So when folks kind of come in to see us and then need to go to the hospital hospital, imaging, our specialists. It's very seamless. They feel that they're, kind of part of one big team. That's what we're kind of working towards. And finally, this last slide just kind of shows through some shadowing of physicians, we got some data. On a typical 9.5-hour workday, this is on average what the average, sort of the primary care doc was kind of looking at as far as time-wise. The red is what we want to get down. This is the non-patient contact duties. This is our emails. This is mail. It's forms filled out. It just kind of adds up. So the hope is to get that 3.5 hours and really cut it down through our different phases as we sort of implement the primary care change so that we can build more of those green boxes, that free time back to the docs, so they can grow practices, they can code, they can get their work done before going home and not logging in at midnight to try to finish documentation. That's the hope. The hope is that if it works and it works well, that's what we're hoping to achieve. That's it. Thank you very much. So thank you. I don't know if you want to do polling questions.
Yeah,
I have
I
just
tell
a
you
couple.
what, why don't we do it in transition?
Okay, perfect.
Because we're running a little bit behind.
I know, I'm so sorry. Lee's coming up right behind me, but really just to get some feedback from you folks, especially our primary docs too, is how many hours per week do you currently spend on pre-visit prep? So everything from 10 or more, 5 to 9, fewer than 5, or I just don't do pre-visit prep. So. Great. Wow, 10 or more hours. Who are those? Holy cow. I hope it's not the folks in the pilot program. Are they doing, yeah, hopefully that didn't add to the pre-visit prep. Nope, great.
Go on up.
Thank you. Yeah,
Looks
let's
like
move
it's
on.
stabilized.
Yeah, very nice. Thank you for the input, folks.